Very good morning, everyone. Today, myself, Dr. Ajay Gupta, I'm a reader in Department of Prosthodontics, Mahatma Gandhi Dental College Hospitals. Today we are discussing the fluid control and the tissue management in fixed prosthodontics. So we are covering this topic under following headings. We are starting with the introduction. We have methods for fluid control. We have methods for gingival displacement and the conclusion. So starting with the introduction, firstly, the need for fluid control, why it is needed, and second, need for gingival displacement, why we should need the displacement of our gingiva. So what is fluid control? It refers to excluding the circular fluid, saliva and gingival bleeding from the operating field. It refers to preventing the handpiece, spray and restorative materials from being swallowed or aspirated by the patient. So starting from the source of moisture in the clinical environment, like that is the mouth. So from where we are getting the moisture and the fluid. So the first and foremost thing in the saliva, the salivary glands, we have the parotid, submandibular and sublingual glands. They are producing saliva all the time. Then the blood from the inflamed gingiva tissues or the iatrogenic damage. Then how is moisture control important? The first, from the patient concerned, we have the patient related factors, like it provides comfort to the patient also, and it protects from swallowing or aspirating foreign bodies with the saliva. And for the task or technique being performed, the dental materials are moisture sensitive and success of adhesion and physical properties relies on a dry field. Then for the operator concerned, we have the operator related factors like infection control to minimize aerosol reproduction. If the patient's mouth will be filled with the saliva or the salivation, then the chances are more of aerosol generation. Then it increases the accessibility of operative area or operative site, then improves the visibility of working field. Then it less fogging of the dental mirrors and it prevents the contamination. So they are the basic objectives, like isolation, retraction and the accessibility. We need a dry, clean operating field. We need access or the visibility in the operating field. We have to enhance the properties of dental materials to protection of the patient and the operator. It increases the operating efficiency and successful impression making. So if we classify the methods of fluid control, we have the mechanical, we have the chemical and the others material. In the mechanical methods, we have rubber dam, we have high volume evacuator, we have saliva ejector, swab adapter and the absorbance points. So you can see the rubber dam, how it is placed to isolate the area of the working area. So the basic use of rubber dam for core build-up or pattern fabrication, impression making of inlays, onlays, removal of your old restoration and caries, and for cementation process. And we cannot use this rubber dam. It should not be used with polyvinyl siloxane because it interferes with the polymerization reaction of your material and the patient who are allergic to latex. There are certain advantages of this rubber dam. It can isolate one or more teeth very nicely, and it eliminates the saliva from operating site and it retracts the soft tissues very nicely. And there are certain drawbacks of this because it is a lengthy and time consuming process, so patient objection may occur, and it is unusual to shapes or the position that cause inadequate clamp placement, and then you have partially erupted teeth or broken down teeth, and the patient suffering from asthma, so you cannot close the patient's mouth with your rubber dam. So this is a basic set of a rubber dam. So in that we have the rubber dam punch, rubber dam clamp, rubber dam clamp forceps, rubber dam frame and holder. Then we have the high volume suction or high volume vacuum. It is a powerful suction device used for 10 mm diameter SVE tips and a properly functioning suction pump set to evacuate the saliva or this fluid from the mouth. The apparatus also removes small operative like debris, or it is excellent lip retractor, but there are certain drawbacks. It cannot be used for impression and cementation procedure. Then we have the small saliva ejectors. It is a low vacuum suction devices that the speed of your suction is 300 ml per minute in the suction rate. Rather to the high volume evacuation or vacuum, a rubber dam or cotton rolls, we can use it also. So uses removes the saliva from the floor of the mouth and removes the water slowly. Now there are certain types of salivary tubes that we can use. It can be transparent, it can be multicolored, hygroformic saliva ejector. We have mirror vacuum and lingular fixes. Then we have again we have a reusable tips like formed with the steel or with the tongue guards. Then we have the swab adapter. It is a metal saliva ejector with a tongue retractor. It is used for mandibular arch, most effective when the patient is in nearly upright position. Then we have the absorbance points, like cotton rolls and the cellulose wafers used in the short period of isolation. Along with the saliva ejectors, it reduces the salivary flow, and we can place it either side of the tooth or the working area. These are the cotton rolls. These are the commonest and the cheap that we are using in the day-to-day life. That the preparation in the maxillary arch or in the mandibular arch, we can use the cotton rolls. So these rolls controls a small amount of moisture and it retracts the cheek and tongue. It keeps it safe and does not fall apart when full of saliva. It provides acceptable dryness for procedures, and we can use it in the cementation procedure and the impression making procedures. Now, different type of cotton rolls are wrapped and braided we can use. Then we have the cotton roll holder. It holds the cotton roll into place, and basic advantage of this, it is cheek and tongue are slightly retracted, so iatrogenic errors are less. Then it enhances the visibility of your working area. Then moisture absorbing cards we have that these are the pressed paper wafers that covered on one side with the refractive foil. So paper side is placed against the dried buccal tissues and attached to it, and in addition to it, the cotton rolls are placed in the adjacent mandibular and maxillary vestibule to control the saliva, and they displace the cheek literally. We can use the dry tips and reflective shields. The dry tips are basically cotton wafers and we can use in the area, and reflective shields are also there that slightly reflect the buccal tissues or the lingual tissues from the working area. Now we have the chemical methods for fluid control, that the patient is having excessive salivary flow, so we can give the medicines like antisaligogues and local anesthetics to reduce the salivary flow. So you all well known about the local anesthesia and the mechanism of action. There is a low impulse from the periodontal ligament form a part of the mechanism that regulates the salivary flow. So when they are blocked by an anesthetic, or the salivary reproduction is considerably reduced, and a dentin hypersensitivity during the preparation also triggered increased salivary flow, which is blocked by the local anesthesia. Then we have certain medicines. It is given for the patient who has salivary excessively. Now we can use anticholinergic drugs like gastrointestinal anticholinergic that acts on the smooth muscles of the gastrointestinal, urinary and the biliary tract, producing a dry mouth as a side effect. Drugs that we can use is benthine or probenthine, 50 mg tablets taken 1 hour before for appointment, that is for the benthine. For the probenthine, it is 15 mg tablets taken 1 hour before for the appointment, and duration is of working is 1.5 hours, or action within 5 to 10 minutes it can start. And there are certain side effects of these medicines like drowsiness and blurred vision or unpleasant taste. Now we have the intraoral injection of probenthine, that 2 to 6 mg, and onset of action of this injection is 5 to 10 minutes, and duration of action of approximately 1.5 hours. And drying effect prolonged by injecting probenthine or propanthenol 2 to 3 mg after 1.5 hours. Now there are certain contraindications of these drugs, like drugs hypersensitivity. The patient is having certain sensitivity reaction, then we can use this. We cannot use this. And then in the glaucoma, in the asthma, in the asthmatic patient, in obstructive disorders of gastrointestinal tract, and in congestive cardiac failure or in lactating mothers, we cannot use these drugs. Then we have the clonide hydrochloride. It is an antihypertensive agent. The required dose is 0.2 mg, that is 1 hour before appointment we can use, and should be given cautiously in patients who receive other hypertensive drugs, and because of the sedative effect of the drugs, someone should accompany the patient. Now coming to the tissue displacement, it is changes in the form of the position of the tissues used as a result of pressure. It is a deflection of the marginal gingiva away from the tooth, and there are certain synonyms of this like gingival retraction or gingival displacement. So reflect gingiva and produce the enlargement of the or to dilate gingival sulcus is the basic aim of your gingival displacement, and to obtain 0.2 to 0.4 millimeter of horizontal displacement of marginal gingiva, and to achieve 0.5 millimeter of vertical exposure of unprepared portion of your tooth. So why do we have to retract the gingiva tissues? The first and foremost, it is retracted to obtain maximum exposure of your finish line. Then gingival retraction permits the completion of the preparation and cementation of the restoration, and helps to, the operator to make a complete impression of your preparation. So thank you very much. Have a good day.